The next presenter, I'd like to introduce Lauren Turner. And Dr. Turner is an RMO completing her surgical year at the Canberra Hospital. Her interests obviously in general surgery, research and quality assurance. Please welcome Lauren.
Thanks, Dr. Aya. Okay. Can everyone hear me?
Yes, that's great, Lauren.
Perfect. Okay. So hi, my name's Lauren. I'm a surgical RMO at Canberra Hospital, currently on ASU, and I'll be presenting audit data on melanoma patients who underwent both a sentinel node biopsy and a wide local excision for melanoma by 3 surgeons between January 2016 and December 2017. So just a bit of background, we know that melanoma is a growing problem in the context of an ageing population. It's now the 3rd most commonly diagnosed cancer. Immune therapies are here now, and sentinel node biopsy is the gold standard of treatment, and it allows us to stratify patients for adjuvant therapy. It's minimally invasive. It's got 2 stages. We've got a preoperative lymphocytogram scan, which maps the nodes with a radioactive tracer, then the injection of a blue dye at the site of the primary lesion, which allows us to identify the path of lymphatic drainage. The nodes that are stained represent the sentinel nodes, and then they're selectively biopsied to determine whether or not they're involved in the disease. So sentinel node biopsy improves prognosis. It identifies and removes the disease early. And we know from longitudinal studies such as MLST1, which spans 2 decades, that sentinel node biopsy improves both immediate and 10-year survival. As I said before, it stratifies patients for adjuvant therapy, such as immune checkpoint inhibitors, BRAF and MEK, and those on their own also improve survival. So if you've got a melanoma over 1 millimetre with a positive sentinel node biopsy, you're eligible for adjuvant therapy. We also know that you've got a better outcome if you have a sentinel node biopsy with the node removed and positive versus a regional recurrence. But because of the fact that it's the gold standard, that means there is such a need for quality assurance. There's several points for error, as you can imagine. You've got the preoperative imaging, you've got the surgical resection itself, and you've got the pathology aspects to take into account. So what quality assurance parameters are used in the literature? So the most crude measure of quality assurance for sentinel node biopsy is the identification rate. This is just simply saying that the procedure managed to identify a node. We'd expect in around 90% of cases that we would find a sentinel node. Other variables are slightly more complicated. So you've got sentinel node biopsy completeness. This simply means you've managed to remove all nodes that have been identified, and then incomplete. So you've retained some nodes that were identified. This is going to be affected by multiple things in the literature. As you can imagine, you've got tumour factors, things like Breslow thickness, patient factors, so age, and you've also got hospital factors, like volume of cases. It's also interestingly affected by the region, and it's affected by surgeon. If you've heard the terms positive and negative before and you weren't sure what they are, I didn't know what they were, that just simply refers to the histological status of the node itself. So the final measure of quality assurance that we look at is the false negative rate. So that's a relapse of a regional node after a negative sentinel node biopsy. This is obviously going to be associated with an increased risk of local in-transit disease recurrence, which explains the false negative sentinel node biopsy in some instances. Again, that's going to be affected by both patient, tumour and technical factors. The literature tends to propose a cutoff rate of around 15% as an acceptable false negative rate. So what do we do? So we selected all patients who underwent both a wide local excision and a sentinel node biopsy for melanoma at Canberra and Calvary Hospital between January 2016 and December 2017. We excluded 9 patients. We excluded for a number of reasons. Some people had a lymphocytogram but didn't go on to have a sentinel node biopsy for whatever reason. Some patients didn't have a wide local excision. Then we looked at our measures of quality assurance, as I stated before. So rate of identification, number of complete versus incomplete, the false negative rate and the calculated false negative rate. And this was over a follow-up period of around 24 months. Here you can see our basic demographics. The main thing I want to highlight here is our large proportion of thin melanomas. So you can see that around 60% of our cases were between T1 and T2 Breslow thickness. So that's quite thin melanomas comparative to the literature. You can also see this reflected in the percentage of microsatellites present. So thinner melanomas, less of a tendency towards microsatellites and things like ulceration. Here you can see our rates. So our node identification rate was 99.1%. So we managed to identify a node in all but one case. Then you've got a rate of completeness. So we removed all identified nodes in 81.2% of cases, and that did not vary significantly by region. So axilla versus groin versus head and neck. Rate of incompleteness was 18.8%. That also did not vary according to region significantly. Our false negative rate was 1%, and our calculated false negative rate was 7.14% at 24 months. So you could argue that you'd expect that to be around 14% at 48 months. Here's our oncological outcomes. So for the majority of cases, 82.9%, you had surveillance with no recurrence, which is reassuring. So overall, our data is pretty reassuring. We identified a node in all but one cases. Our rate of incomplete sentinel node biopsies was pretty on par with that of the literature. While our false negative rate was lower than that of the literature, as I said before, this probably reflects two things. First of all, the duration of our follow-up. So you'd expect a false negative rate to increase over a prolonged duration of follow-up. It would be correlated with duration of follow-up, I should say. But it also probably reflects the fact that we've got thinner melanomas in our sample. So 80% of our melanomas were less than 2 millimeters and 20% less than 1 millimeter. That's going to reduce the false negative rate. 7% we think is likely just because the true positive rate is so low. And while that's reassuring, I guess the one thing that I really think that, and we will go on to look at for publication, is how many interval nodes that were present in terms of looking at the lymphocytograms and seeing whether or not that is actually correlated as well with some of the melanoma factors. Okay.
Lauren, thank you very much. Has anyone got any questions in the audience? Look, it's interesting to note that there was a female-male discrepancy, and also the earlier tumours. Is there anything specific to Canberra that makes us slightly different to other studies or other populations?
I was thinking that we're a smaller centre. We aren't actually a small centre per se, but this is based on sort of 3 surgeons. So we've got a less of a volume of distribution to look at. Whether or not that would be a factor, prolonging the follow-up, I think, would be something that would give us a bit more information about whether or not there is a regional factor.
Yep. Yeah, no, that's excellent. And the male-female discrepancy, is that repeatable in other populations as well, or?
No, I haven't seen that before. I would need to look more at the data though.
Yep.
You're referring to the demographics here?
Yeah, that's right. Yep.
Yeah. No,
that's excellent. So any other questions? I think Phil Cheer sort of asked similar sort of questions about why Canberra has that thinner thinner melanomas overall. Are there any sort of emerging techniques that will improve sentinel node rate or reduce the false negative rates that you're aware of? This is from Phil.
I was just thinking on the point about thinner melanomas. Maybe that could be reflected in Canberra's population in terms of having a higher median income and people being able to present earlier melanoma for whatever reason. And sorry, what was the second part of the question? The second was,
are there any emergent techniques for improving sentinel node pickup rates and reducing their false false negative rates?
That's a tricky question, Phil. not that I'm aware of. I guess all I can say is sort of robust quality assurance measures and looking at whether or not there are factors in particular centres. The workload itself might be affected by if centres are getting referred more difficult cases, that's obviously going to be a factor affecting their own false negative rates and things like that, false positive rates rather. And so that obviously should be taken into account. I guess the quality of the lymphocytograms is something that all of these patients all would have had lymphocytograms done at CIG. So that's a factor as well. Even just looking through the reports, there's a lot of variability in how lymphocytograms are reported. And we found we actually had to check the images themselves. So the report was often, I don't want to say inadequate, but it wasn't enough information in every report comparatively. So standardizing lymphocytograms themselves, with looking at the centers that perform these measures and what their own quality assurance measures are, is probably one thing you could do. And that's obviously the imaging side of things. From the surgical perspective, I guess looking at the histological reports and looking at what what the volume of workload for that particular surgeon would be part of looking at that as well.
Excellent. Look, Lauren, thank you very much for presenting your work today. That was excellent.
That's right. Thank you.